Hi guys, thank you for coming today. So I'll just wait for more of you to join and then I'll get started. Okay, I'll just get started now, and people can just join at their leisure. Okay, so you guys should be able to see my screen and yeah. Okay, so welcome to the final OSME lecture. So today we'll be talking about CNS and biochem. So if I'm going too fast or if you guys have any questions, then please just interrupt me and let me know, and I'll be happy to go a bit slower and go over some topics. Okay, so these are the spec points we'll be covering today. So there's a focus on CNS hemorrhage and understanding what the different types are, also the histology of various types of tumours and also how they present clinically. And then also moving on to neurodegenerative diseases, which you guys have covered in preclinical, and MS, Guillain-Barré, stuff like that, and also finishing off with meningitis and encephalitis. And then the second half is more biochem, so we'll be doing acid base and calcium regulation, things like that. So quite a lot to get through today. Okay, so starting off with CNS trauma. So there are two types of brain injuries that you need to know about. So a contusion. So a contusion is essentially a bruise of the brain, and it's due to small vessel injury, which leads to edema. And you have coup injuries. So coup is on the side of the traumatic incident, and you have contra coup, which is on the opposite side of the brain, and it's due to the shift of the brain due to the impact, causing a bruise on the opposite side. And you also have a laceration. So a laceration is a tear of the brain tissue. And then you also have stroke. So a stroke is defined as a sudden onset focal neurological deficit, and it has to be greater than 24 hours. If it's less than 24 hours, then it would be a TIA or a transient ischemic attack. And that differentiation is really important. So you can't classify a stroke without that time period limit. Okay, and 80%, so the majority of strokes are ischemic due to clots in the brain, and the rest are hemorrhagic. And that differentiation between the two is really important because you want to do a CT head to rule out a hemorrhagic stroke before you treat an ischemic stroke, as otherwise the thrombolysis could worsen a hemorrhagic stroke and kill the patient. The risk factors for a stroke are essentially just the same as any cardiovascular risk factors, so MI, whatever it is. So the risk factors are smoking, high blood pressure, and also diabetes. Okay, so these are the main types of brain hemorrhages you guys need to know about. And this is quite high yield, so it's worth kind of going through each one on this list and being comfortable with what they look like on imaging and also how they present acutely. Okay, so extradural is this one here. So extradural is outside the dura and it is limited by the cranial sutures. So it has this characteristic lemon shape, in contrast with the subdural, which has more of a banana or a crescent shape. And we'll be talking about how they present, but this is kind of very serious and acute and has a lucid interval. Okay, and then a subdural is venous bleeding due to tearing of the bridging veins. And this can be either acute or it can be chronic. So, or it can be both. So you can have acute on chronic presentation, where an acute incident like trauma, so if someone falls over, could kind of rapidly worsen a chronic subdural bleed. And you can also have subarach. So that's an intracerebral hemorrhage, as you can see here. It's kind of more diffuse throughout the brain rather than the kind of well-defined extradural or subdural. And that's the classic thunderclap headache in the history. So patient feels like they've been hit on the back of the head with a cricket bat. Okay, so this is a really useful slide for your notes. So here we have intraparenchymal. So this, as you can see, is inside the brain parenchyma, and it's a really well-defined kind of pale lesion compared to the rest of the brain tissue. And the main causes of an intraparenchymal bleed are high pressure. So hypertension can damage the delicate blood vessels of the brain and then lead to a bleed. Also trauma, AV malformations, tumors, etc. So quite a few different causes for this one. And it can be arterial or venous. And like I said before, it has quite a well-defined round appearance and it's very acute. So the patient might present with systemic symptoms, so nausea, vomiting, depending on the size of the bleed and where it is. Okay. And then we have intraventricular. So this is within the ventricular system of the brain. So as you can see here in the lateral ventricles, you have this area of blood, and this can be either due to intraparenchymal or it can also be due to subarach hemorrhages. So in a subarach, it might just present with enlargement of the ventricles, hydrocephalus, and also blood pooling within the ventricles as well. And yeah, it's localized. Classic presentation like the one before. So nausea, vomiting, headache. And then subarach is between the arachnoid and the pia, and they can be quite difficult to see on a CT head. So you might see it as enlargement of the ventricles, you might see it as blood, and you might see it as this kind of star shape here, and that's known as the star sign. And the main kind of mechanism of a subarach is rupture of an aneurysm. So there are some conditions that increase your risk of getting aneurysms. So, for example, in polycystic kidney disease, some of these patients develop berry aneurysms, which can then burst and then give you a subarach hemorrhage. Very acute presentation. So, in a lab med question, it's always going to be the worst headache of your life, or just words to that effect. Something very dramatic and very sudden. So they might just be watching TV and then all of a sudden this comes on and then everything kind of changes and they need to get to the hospital. Okay, and then a subdural is, you can see it here, it's quite subtle, but you can definitely see that kind of crescent shape there. And it's not limited by the cranial sutures, unlike the extradural. The main kind of cause of a subdural is trauma, but it can just occur in the elderly, just if, for example, if they're alcoholics, then they will be predisposed to it. So it doesn't need to be, there doesn't need to be trauma present for you to have a subdural. And it's due to tearing of the bridging veins, and it can be insidious as a worsening headache. Finally, extradural is between the dura and the skull, and classically due to trauma, but it can also happen post-surgery. And it's an arterial bleed, most commonly of the middle meningeal artery. And the middle meningeal artery is sat at the pterion, where the different bones of the skull meet. And this is a point of fragility. So if you're, hit with like a cricket bat, and there's kind of trauma to that area, then it could rupture the middle meningeal artery and give you an extradural. So, yeah, the patient would have an altered mental status if that happens. Okay, so this is a bit about the clinical presentations. So, how an extradural presents is you have the kind of traumatic incident and then you have a lucid period. And during that lucid period, you're fine. So, you'll be kind of going about your everyday life and you don't feel too bad. And then all of a sudden, you start deteriorating. So you become drowsy, you become confused, and then eventually you lose consciousness, and that's when you end up in hospital. So yeah, if someone has a high impact sports injury in the question stem, you'd be thinking extradural, and yeah, you'd want to get them a CT head. Okay, and subdural, it's really important that you guys recognize the risk factors for a subdural. So, main risk factor is age, also alcohol dependence. So those are the two main ones, and also if they're on any anticoagulants. So just remember those three. And also if they have like a gradual worsening headache or cognitive decline, then this could be explained by a gradual subdural hemorrhage. Okay, and subarach, we talked about how it presents, hypertension, risk factor, polycystic kidney disease. So if you see like baryaneurysm in the question, think subarach. And yeah, I talked about these. Okay, cool. So I'll leave this slide on for a bit in case you guys want to make some notes. Okay. Okay, so now we're going to move on to the different types of brain tumor. So in this presentation, I'm only going to talk about primary brain tumors, so the ones that originate in the brain. But don't forget that the most common types of brain tumors are actually metastases, so from other sources in the body. The main type of cancer that metastasizes to the brain is lung, but then breast cancers also spread to the brain, and so do bowel cancers. Also, melanomas are another one that commonly reach the brain. Okay, so how might a brain tumor present? So the clinical signs of a brain tumor, most commonly a headache, a worsening headache over time, cognitive difficulties, seizures, depending on how large the tumor is and what structures it's kind of affecting. Also, focal neurological deficits, which, yeah, once again, depends on the location of the tumor. Okay, so because a tumor is essentially just a space occupying mass within the brain, and the brain is, enclosed by the skull, there's a limited kind of amount of space and a limited amount of pressure that can be present in that space. So if you had a tumor, you would have a raised intracranial pressure, and you'd have this, and the signs of that would be a headache, but particularly a headache that's worse when you wake up first thing in the morning because you've just been lying down, and that increases the pressure in your brain. Also, when you cough, because that also increases the pressure, bending forward, anything like that. Nausea and vomiting, very common symptoms, and papilledema, which is swelling of the optic disc. And you can look for papilledema by doing a fundoscopy. Okay, so here's another useful summary slide. Okay, so brain metastases typically show up on a CT head as multiple lesions throughout the brain, and they're quite well defined with good borders, and they're often contrast enhancing. So, like I talked about before, these are the main kind of cancers that spread to the brain. It's worth remembering this list because that's quite an easy, like multiple choice question they could ask you, and it's not the kind of thing that you'd intuitively know if you didn't kind of learn it. So just remember lung is like the main one that's likely to spread to the brain. And brain mets have a very poor prognosis, so that typically would just mean palliative care. Okay, so moving on. So meningioma is quite a benign condition. It grows quite slowly, so it would present with a gradual onset headache over the course of months, also a visual disturbance and kind of focal signs. So it might present with change in personality, or if it's in Broca's or Wernicke's area, maybe changes in speech production or perception, things like that. Um, Sorry, it wouldn't be there. That's wrong. It's on the meninges on the outside of the brain. Scratch that. Sorry, guys. So older adults, female, if you have neurofibromatosis too, if you're Afro-Caribbean as well, you have a higher risk of having a meningioma. And a CT head would show a single convex lesion that's on the outside of the brain because it's a tumor of the meninges. It has quite good prognosis and it can be taken out with surgery. So this would be graded as a 1 or 2 on the WHO grading system, which is what they use for brain tumors, like primary brain tumors. Okay, so moving on, glioblastoma, opposite end of the spectrum. So this is like quite severe, very aggressive tumor. So classically presents with a short history of a headache. And in the question stem, this will be in a period of weeks, and that's the main thing that gives away the fact it's a GBM. So if it was a meningioma, months, GBM, weeks. And it would also present with seizures as well, as it kind of in the late stages. So headache and seizures, you'd be thinking GBM. Risk factors, once again, neurofibromatosis 1 or 2, which it's a very rare condition, but it does massively increase your risk of these primary brain tumors. Also, being an adult male as well, you have a higher risk. On a CT head, you'd see a butterfly lesion, which is why this tumor is sometimes called a butterfly glioblastoma, and it crosses the corpus callosum. It has a very poor prognosis, and it's a WHO grade 4, which is the most advanced type, and it does spread very rapidly. Finally, we have medulloblastoma, which is primarily a tumor you get in children. So this has a short history of headaches. So once again, a history of weeks rather than months. Also, behavioral changes, and because it affects the cerebellum, you'd have various cerebellar signs like ataxia, which is kind of lack of coordinated gait. So yeah, just remember children. So if it's a child that's presenting with kind of cerebellar signs and a headache, then you'd be going more down the diagnostic route of a medulloblastoma. So on a CT, you'd see a lesion in the posterior fossa. And this is really difficult to access because of the location of the cerebellum, which makes surgery just very difficult. And that leads to a poor prognosis, unfortunately. And this is also a WHO grade 4.
Hello.
Uh, Um, so about histology, so this is what the different types of tumor would look like. So this looks like so there are key words for the histology. So for lab med, you don't ever have to interpret histology images from just looking at them. They normally give like a description, which you're meant to kind of read and then understand what the diagnosis might be. So, key words for each of these: meningioma, you'd have these things called psammoma bodies. Also, you'd have these calcified whorls, as you can see there. They have these like concentric rings, and that's what would kind of give away the fact it's a meningioma. So brain mets would look like their primary tumor, wherever that's from. Glioblastoma have palisading necrosis. So necrosis is a feature of quite a high grade advanced tumor. So that's what that would have. Medulloblastoma would have rosettes. So these kind of areas here. And I remember that because you give rosettes to kids. So medulloblastoma affects kids. Yeah. Okay, so PNS tumors. So there are many, many rare cancer syndromes. So these are these are some of them. So starting off with neurofibromatosis type 1. This is caused by a mutation in the NF1 gene, and it gives you neurofibromas, which are tumors you get on your nerves. And also these cafe au lait spots, which are these big kind of, they can be big, they can be small, kind of tan brown spots on your skin. Iris hamartomas in your eyes, optic nerve gliomas, and also pheochromocytomas of your adrenal gland. And to look for that, you would do an abdominal ultrasound. So you can also have another type of neurofibromatosis, which is type 2, and that's due to mutation in the NF2 gene. And in NF type 2, you don't actually get neurofibromas, which is quite funny, how they've called it that, but that you wouldn't get neurofibromas in type 2, just type 1. And in type 2, you get vestibular schwannomas, which are tumors which on your cranial nerve 8, the vestibulocochlear nerve. Um, but yeah, so it would be in the vestibular part of that nerve. Okay, so the other kind of familiar cancer syndromes you have to know about are Li-Fraumeni syndrome, and that's caused by a mutation in the TP53 gene. And this predisposes you to developing every type of tumor, including malignant ones. So yeah, most people with this mutation go on to develop various cancers, so sarcomas, breast cancer, just many different types of cancer at a very young age. So quite a serious syndrome. And also gliomas and glioblastoma. So they'd have an annual MRI brain to just kind of rule those out. Okay, and the last one is von Hippel-Lindau syndrome. This is caused by a mutation in the VHL gene, and I think the VHL gene is involved in like hypoxia signaling and HIF, that kind of pathway. So this increases your risk of renal clear cell cancers, pancreatic neuroendocrine tumors, and pheochromocytomas again. So quite a few different cancer syndromes increase your risk of pheochromocytomas. Also, benign tumors of the brain called hemangioblastomas in 10 to 20% of the patients. So this is quite annoying to learn just because it's a lot of memorization, but I think it's worth learning the main presentations. You don't need to learn all the small print details, but just the main types of tumor that these conditions predispose you to. Oh yeah. And in NF type 2, you also have meningiomas and ependymomas. Ependymomas are tumors of the ependymal cells of the choroid plexus, and the choroid plexus is responsible for the production of the CSF, which circulates throughout the ventricles. Okay. Okay, so this slide is on brain herniation. So herniation is where the brain herniates or moves down outwards of the so it's can't so sorry when the pressure is increased and the brain essentially herniates down past the cerebellum into the spinal cord. And if you had herniation, you would see Cushing's triad. And in Cushing's triad, you would have a raised blood pressure, you'd have bradycardia, so a reduced heart rate, and also irregular breathing. So if you see any of these three mentioned in a question stem, you'd be thinking of herniation. And herniation is a very serious condition, and you'd want to call a neurosurgeon for that. And there are different ways in which the brain can herniate, as you can see in this diagram, but you don't have to know about them. That's just for interest, in case you're wondering. And importantly for lab med, you should never do a lumbar puncture if you think that the patient has a raised intracranial pressure. So this is an absolute no-go. So if the patient is presenting with any signs that they might have increased pressure, so they might be confused or they might have any of Cushing's triad, then you don't want to risk it and you'd want to send them for imaging first before you even think of doing a lumbar puncture because that could lead to coning and death. So, yeah, definitely something to avoid. Okay, so we finished that part of the lecture. Now we're going to move on to neurodegenerative diseases. Okay, so starting off with Alzheimer's. So in Alzheimer's, the pathology is you get that buildup of beta amyloid plaques, and that leads to neurodegeneration over time. So the first presentations that of Alzheimer's would be short-term memory loss. So the long-term memory, so for example, a patient's childhood, what they liked doing before, that kind of stuff, that would only be lost a lot later down the line in Alzheimer's. But the main thing that goes is short-term memory loss. So forgetting where you kept your keys, forgetting that you had a hospital appointment, that kind of stuff, what you had for breakfast, conversations you had with people, that is what would go first in Alzheimer's. And it would cause a general cognitive impairment, loss of speech, and in late stages, it would even cause dysphagia, and patients would struggle to swallow, eat, drink, things like that, which is really just very detrimental. So it typically affects older people, people with a positive family history, Down syndromes, as well as people with various versions of the ApoE gene are at a higher risk of developing Alzheimer's disease. And if you were to do an MRI scan on individuals affected by this disease, you would see enlarged ventricles and also damage to the temporal cortex. So that's where the hippocampuses, and you would see degeneration of that area and also cortical atrophy. So the actual size of the brain would be a lot smaller than in a healthy individual. And importantly for LabMed, on histology, you would see beta amyloid plaques, and these are outside the cell. And inside the cell, you would see tau tangles, so hyperphosphorylated neurofibrillary tangles. And to treat Alzheimer's, you would use cholinesterase inhibitors. So that prevents the breakdown of acetylcholine by the esterase enzyme, and it increases levels within the brain overall, which kind of maximizes the availability of acetylcholine in the synapses to try and preserve as much of that neurotransmission as you can. And moving on to vascular dementia. In vascular dementia, you have multiple infarcts throughout the brain, and they vary quite a bit in terms of their chronological progression. So vascular dementia is the classic stepwise decline. So every time you get a new vascular event, you have a decline in cognitive function, which is why you have that like stepwise change over time. And the first sign of vascular dementia would be kind of like variable, fluctuating cognition. So you might have changes to your attention span, your mood, affect, things like that, and also like a mild cognitive impairment. And this over time progresses to more of like a generalized cognitive impairment as more vascular events happen and the number of infarcts you have grows over time. So, vascular dementia is more common in older people, also people with a high blood pressure, cardiovascular disease, especially people who've had strokes before or have a family history of strokes, a vascular disease in any form, so people with diabetes, people who smoke, things like that. So, on an MRI, you would see multiple old infarcts, so dead areas of the brain, and these are going to be quite small, but there'll be quite a few of them. And that would show up as echogenic areas primarily in white matter tracts of the brain. And on histology, you would just see fibrosis because that part of the brain is dead. It's not getting any blood and it will gradually fibrose over time. Okay, so the main way to kind of combat vascular dementia is to treat the risk factors. And the main risk factors are just those cardiovascular ones. So put them on statins, lower the blood pressure, ACE inhibitors, things like that. And then supportive in like the late stages of the disease. Okay, so now we have Parkinson's and also prion diseases. So in Parkinson's, you have motor deficits. So you have tremor, rigidity, bradykinesia, and also like postural instability. So you can remember that by TRAP, so tremor, rigidity, akinesia, and postural instability. That's what I use to remember the kind of cardinal symptoms of Parkinson's. And you also have Lewy body dementia. So, Lewy body dementia has Parkinsonian features, but it also has some added features. And the added features would be visual hallucinations. So a lot of the times, the visual hallucinations involve animals. So the patient might see, I don't know, like an elephant in the room or spiders, things like that. Also, sleep disorders. Very common. The main kind of predisposing sign that someone is going to get Parkinson's is changes to their REM sleep. So if they have a REM sleep disorder, then there is quite a high chance that they will go on to develop Parkinson's. And over time, these kind of early features progress into a generalized cognitive impairment in Lewy body dementia. So an MRI of the brain would show atrophy of the basal ganglia and the temporal cortex. And if you did a cross section of the substantia nigra, you would see depigmentation of that because the dopaminergic nigrostriatal neurons are lost. And Parkinson's is something you cover quite a lot in preclinical, so I feel like you guys are probably quite comfortable and confident recognizing it and kind of understanding the histology. So the histology would show intracellular Lewy bodies, and these contain alpha synuclein. And the treatments for Parkinson's are L-DOPA. So you give them a version of precursor of dopamine that would then cross the blood-brain barrier and then be converted into dopamine, and that would act as a replacement for the loss of dopamine, loss of the dopaminergic neurons. And also, recent advances have allowed deep brain stimulation to be used, and that is very, very effective at treating Parkinson's. And for Lewy body dementia, you can also give acetylcholinesterase inhibitors, like we talked about before, for the Alzheimer's disease. Okay, so now we're going to move on to prion disease. So in prion diseases, you have exogenous misfolded proteins, and these kind of progress very rapidly, and they behave like infectious particles, but they aren't infectious in the conventional sense. So the most kind of famous type of prion disease is CJD, or Creutzfeldt-Jakob disease. And this is very serious, very rapidly progressive dementia. You have cerebellar problems like the ataxia we talked about before. And if it's beef related, or mad cow disease, as it was called, it presents with a psychiatric disturbance first, and then the classic kind of progression into cerebellar ataxia, dyskinesia, stuff like that. And you also have Kuru, which is dementia, and it's related to cannibalism in certain parts of the world and tribes. And if you had a prion disease, you would have lesions throughout your brain parenchyma, and they create these kind of spongy holes in your brain tissue. So you'd see those vacuoles on in the cortex on a post-mortem. And if you were to take a histology slice and look at it under a microscope, you would see loss of the neurons, and you'd also see like beta pleated sheets of the prion proteins. And between these kind of structures, you'd also have the massive holes and the spongiosis of the brain. So unfortunately, there's no treatment, and it just leads to death because the prions are able to spread through the brain and lose and create like a loss of the brain architecture so quickly. Okay, so here are some useful diagrams about the main kind of features of Parkinson's and Alzheimer's. So, like I talked about before, you have the postural instability, so patients will be hunched over and stooped. Bradykinesia, so if they want to start movement, they'll find that quite difficult. And when they do start moving, so they'll take a while to get up, and then they'll walk quite slowly. with like a short stepped gait, and that gait is known as a festinating gait. And they don't swing their arms that much when they walk as well, and they often like lean more to one side, which is asymmetry of the gait as well. So these are the main features they might mention in the question stem. And yeah, Alzheimer's, loss of executive function, solving problems. They won't remember routes, so they might get lost while driving. They'll forget where they put stuff. Yeah, classic features. Okay, so now we've got Huntington's and motor neuron disease. So there are quite a few different types of neurodegenerative diseases for you to know, but I feel like this section is probably not too bad because you've covered it quite a bit in preclinical. Okay, so Huntington's, you have the CAG trinucleotide repeat in the Huntington's gene, and it classically presents with chorea. So they won't really say this patient presents with chorea in the question. They'll probably say they have kind of involuntary jerky movements or words to that effect, just to make it a bit harder for you. Also psychiatric symptoms, and they also develop dementia at a very early age, typically less than 40 years old. And it has anticipation. So in each generation, the onset of Huntington's gets earlier and earlier as the number of trinucleotide repeats just keeps increasing. And that leads to individuals developing the condition in their 40s, 30s. It's, yeah, horrible condition. And an MRI would show degeneration and degradation of the caudate nucleus, specifically within the basal ganglia. And on histology, you would have fragments containing Huntington in the nucleus, with the cytoplasm around the nucleus actually being spared. And yeah, there's no treatment. So it's progressive and it's, yeah, fatal. Okay, so finally, moving on to motor neuron disease. So this is sporadic and there are loads of different types. So you have ALS, PLS, and various other types. So you'd be thinking of ALS, PLS, PMA if they have asymmetric distal weakness as well as sensory loss. And if they have symmetrical weakness, then you'd be thinking more along the lines of PLS or PMA. And this would have no sensory loss. And for motor neuron disease, this has a there is an increased risk if you have a positive family history, and if you do an MRI in the spine, this might have inflammation or reduction of the spinal volume. And the histology findings that you guys have to know for lab med are atrophy of the neurons, gliosis, as well as activation of the microglia and deposits in the cytoplasm. Okay, so moving on to demyelination. Okay, this is quite content heavy, but I will try and make it like break it down for you guys to make it more understandable. Okay, so MS. MS is where you have an autoimmune response to the myelin in the CNS specifically, and this is an autoimmune reaction to the myelin produced by oligodendrocytes. Whereas in Guillain-Barré, it's an autoimmune reaction to the myelin in the PNS, which is produced by Schwann cells. Okay, so the main kind of features of MS are focal neurological signs. So the patient is often a young woman and she has like a loss of vision in one eye. And then, a few months later, she might have like numbness and tingling in a leg. And then maybe she has kind of loss of sensation when she goes to the toilet. And then the symptoms stop and then they come back. And it's kind of confusing. So MS takes quite a long time to be diagnosed because it has all of these kind of vague symptoms that present isolated in space and time. And kind of piecing those together, it takes quite a while to understand, oh, this could actually be MS. So yeah, diagnosis is quite tricky. And there is no single diagnostic tests, which makes the process like even more difficult. So clinical history, like classic, what I just said. And if someone presented with those symptoms, which are discrete in space and time, you'd want to do an MRI, and you would see enlargement of the ventricles and white matter thinning on the MRI. And you'd also want to do a lumbar puncture. So on a lumbar puncture, you'd see oligoclonal bands, and this is a lab med classic, the oligoclonal bands. If you see that, you'll be thinking MS. And yeah, histology, you'd obviously see decreased myelin because it's been destroyed by the immune system. And you might also see like macrophages, lymphocytes, like signs of an immune response. Okay, so Guillain-Barré presents quite differently. So it has symmetrical limb weakness, so the same on both sides, and it starts peripherally, so normally like at your toes, and that's called a glove and stocking distribution because it starts at the end and then works its way upwards. And then you'd also have areflexia. So you'd start losing your reflexes, and then it typically follows like a flu-like or diarrheal illness. So for example, last week we talked about Campylobacter. So a patient might have food poisoning and sickness from Campylobacter, and then a few weeks later they present and they can't move their legs and they don't have any reflexes, and that would lead you to think they have Guillain-Barré. And as Guillain-Barré progresses, it can involve your respiratory muscles, and this is of course very serious because you won't be able to breathe, and yeah, it can then lead to death, but it is treatable, so hopefully shouldn't get to that stage. There's no single diagnostic test for this as well. So you'd be going off of the clinical history, also doing antibody tests looking for specific antibodies. And you'd also see elevated white cells in the CSF and high protein if you did a lumbar puncture. MRI brain is normal, so you'd want to do an MRI spine, and that would look for, and on that you would see thickening of the nerve roots. And histology, same as MS. And the management is IVIG to get rid of those autoantibodies, also plasma exchange. And if it's late stage and the respiratory muscles are affected, then you'd want to put them on a ventilator to let them keep breathing. Okay, so here's like a cartoon of what I just talked about. So the main feature that you guys should remember is it starts in the lower extremities and ascends upwards. So it affects both limbs at the same time and causes weakness and loss of reflexes. And yeah, MS as well. MS is a bit more vague and it affects quite a few different systems in the body. But if you see a list of symptoms and they don't quite clearly link to each other and they're separated in space and time, think MS. Okay, so moving on to CNS infection. Okay, so this is very, very high yield for lab med. So I think it's really important that you guys get your head around this because it comes up all the time, whether it be the diagnosis or the management. Okay, so meningitis. Meningitis normally presents with a headache, stiff neck, fever, photophobia. And if they have a non-blanching purpuric rash, then you'd be thinking meningitis, but more specifically, you'd be thinking Neisseria meningitidis as the cause of the meningitis. So there are various causes of meningitis. So viral meningitis, management for that is just supportive, and you also have bacterial meningitis. This one is a medical emergency because it has a really high mortality rate, and if left untreated, it has all sorts of complications. It can lead to limb amputation, deafness, so definitely not something you want to neglect. Fungal meningitis, like Cryptococcus, more common in immunocompromised people. Um, TB as well can cause meningitis. So TB meningitis, you'd see granulomas within the brain, and also autoimmune meningitis, which is nowhere near as common as the other types. Okay, so thinking about bacterial meningitis, This is very important. So you have various causes. So if the question says it's a gram-negative coccus, then the answer is Neisseria meningitidis. And this is more common in kind of people our age and older as well. If it's a gram-negative rod, then you'd be thinking Haemophilus influenzae. And this commonly only really affects people under the age of 5, so not really people our age or middle-aged people either. And strep pneumo is a gram-positive coccus, and it can affect people of all ages, and also more commonly people over the age of 50 as well, which is why it's really important they get vaccinated against this particular type as you reach kind of 65 or if you're immunocompromised. And listeria is a gram-positive rod, and it only really affects neonates or people over the age of 60 or people who are immunocompromised. So if your patient is a diabetic, if they're pregnant, if they're old, immunocompromised, or an alcoholic, you'd want to also give them the treatment for listeria, as well as the normal empiric treatment for meningitis until you find the cause, because you don't want to ignore this and the patient gets very sick. Okay, so if you suspect someone has meningitis, then what do you do? So you would have, you would first do a clinical exam. And on a clinical exam, you would look for Koenig's sign and Brudinsky's sign, which are shown in the diagram here. And you'd also want to do a lumbar puncture at the level of L4, L5. So on a lumbar puncture, you would see this if you had bacterial, viral, or TB meningitis. So just quickly going through this table. So bacterial meningitis, you would see lots of neutrophils in the CSF. Viral meningitis, you'd see lots of lymphocytes in the CSF. And in TB, even though TB is a bacteria, you'd see a lot of lymphocytes in the CSF. Sorry, I've got a sore throat, so just drinking a lot of water. Um, and okay, so for bacterial meningitis, you'd also have a lot of protein because the bacteria produce the proteins. And in TB meningitis, especially, you'd have a sky high protein count. So that's how you differentiate TB meningitis from the other types of meningitis. Yeah, look at the protein. So a really high protein combined with a lot of lymphocytes, you'd be thinking TB. And glucose levels. So in bacterial TB, you would have low glucose, and people always say like it's because the bacteria are kind of consuming the glucose. I'm not sure how true that is, but it's a useful way to kind of remember that in bacterial TB, you have a low glucose. Viral TB, it's going to be normal, and sorry, viral meningitis, it'll be normal, and in TB meningitis, you would have a low glucose. So if the CSF is clear, it's likely to be viral meningitis. If it's cloudy or turbid, then it's more likely to be bacterial. And if it's TB meningitis, then you'd have spidery clots in the CSF, and it would be very cloudy due to the high protein levels that we just talked about. So this is very high yield. So spending 20 minutes going over the different kind of presentations of meningitis on a lumbar puncture and the way the CSF would look and knowing the differences is really important. Okay, so moving on to encephalitis. So encephalitis is also very serious, and it is most common in the young and the elderly, so it has a bimodal distribution. And the most common causative pathogen of encephalitis is HSV1, so herpes simplex 1, and it has a really high mortality of 70% if left untreated. and it still has a high mortality of 20% to 30% if you treat it. So, just not a good thing to have. And it presents with a fever, headache, which overlaps with the clinical presentation of meningitis, but it doesn't really have the symptoms of neck stiffness or photophobia. That's how you differentiate it. And in encephalitis, you'd also have confusion and brain dysfunction. So you might also have like seizures and other kind of features. Okay, so moving on to brain abscess. This has a classic triad, and that is headache, fever, and focal deficit. So, a focal deficit is something very specific due to the location of the abscess within the brain. And in meningitis or encephalitis, you wouldn't see a focal deficit, you just see a general deficit. So, that might be in the form of confusion, or you might have seizures or something like that. In If you had a brain abscess, you might also have a headache, which is a very common symptom, also fever, and yeah, seizures, altered consciousness, things like that. And these are the main causative pathogens that you'd be looking out for. Okay, so now we are going to move on to the biochemistry part. But before that, I made some questions for you guys on VBox. So I will share those with you now. Yeah, so if you guys want to join the VBox, that would be good. And yeah, have a go at the questions. Okay, so I think most of you finished answering it. So I will close the poll. And okay, yeah, well done. So the answer is listeria. So why is it listeria? So first clue, 70-year-old man, they're quite old. Watery diarrhea. So listeria does cause watery diarrhea and gastroenteritis symptoms. So they've had that for a week already. And then they have a shorter history of fever, chills, headache, so meningitis, just fairly general symptoms. So that doesn't tell you it's listeria. And then looking at the CSF, it's cloudy, bacterial, 70% lymphocytes. So that's quite unconventional for bacteria. You'd be thinking more neutrophils, but it can be high in lymphocytes for listeria and gram stain, gram positive bacillus, and that's really what gives it away, and that's what cinches the diagnosis as listeria, because if it was strep pneumo, then that would be a gram positive coccus, not a bacillus. So yeah, that's why knowing the gram staining and what each bacterium would look like is so important, because even if like you disregarded the rest of the question, that could still help you get the right answer. So yeah, cool. Next question. Okay. Yeah, well done, guys. So the answer is Neisseria meningitidis. So why is it Neisseria? So they present with fever, neck stiffness, headache. So classic symptoms of meningitis. But they're also confused and disorientated. So at this point, if you don't know anything else, you'd also be worried about encephalitis because they have that generalized neurological deficit. They're confused. That's not good. So then you do some further investigations. They've got neck stiffness, OBS, high heart rate, low blood pressure, high temperature. So that's also not good. They're septic, and they have Carnegie's and Brudinsky's positive. So once again, that's just signs for meningitis and petechiae. So like I said before, if you have that non-blanching purpuric rash, then that is going to point you in the direction of Neisseria meningitidis, but that is not, 100% sensitive and specific. So that's just a clue that points you in that direction, but it's not enough to say, yes, it's Neisseria. CSF is cloudy, suggesting bacterial, high neutrophils, and gram stain, gram-negative diplococci, and that is what gives it away again. So that would be suggestive of Neisseria meningitidis because Haemophilus is a gram-negative coccobacillus. So yeah, not a diplococcus. Cool. Oh, I thought I changed this question, but I don't think it's synced. So, I changed it to what antibiotic should be used empirically before the diagnosis was made. So, sorry about that. It didn't change in the question. Okay, but yeah. So because sorry, this is my fault. The question was meant to be that before the diagnosis. So the empiric therapy for meningitis in Oxford would be ceftriaxone and amoxicillin if you suspect listeria. But in the previous case, you didn't really have much of a reason to suspect listeria, so it would be ceftriaxone as the empiric therapy, um, which most of you guys said. So yeah. Okay, yeah. So the answer is amoxicillin. So it would be yeah, so that's just what's in the microguide guidelines. And if, you know, that would be in addition to ceftriaxone. So ceftriaxone is the just a regular empiric therapy. And if you are pregnant, immunocompromised, elderly, add in amoxicillin because you can't rule out listeria infection just yet. Okay. Um, yeah. So most of you guys got it right. Well done. So this one's a bit tricky. So what are the clues that it's toxoplasmosis? HIV positive, so immunocompromised, 3 week history of forgetfulness and personality changes, and a seizure. So they've got a very low white cell count, so that suggests that they're, very immunocompromised and susceptible to opportunistic pathogens. Looking at the CT head, contrast enhancing lesions in the frontal and parietal lobes, that's going to be responsible for your personality changes and forgetfulness, and these are ring enhancing. So that would lead you to think toxoplasmosis. So toxoplasmosis presents as ring enhancing, contrast enhancing lesions in the brain, and there are multiple lesions. So it's not going to be something like a brain abscess. And yeah, toxoplasmosis is one of the opportunistic pathogens that you'd be worried about in someone with HIV, as it can cause cerebral toxoplasmosis. And this wouldn't typically be something you see in a healthy individual. So, yeah, that's why it's toxoplasmosis. Um, I think some of you guys put herpes simplex because I'm guessing due to the kind of seizure, the forgetfulness, the generalized presentation, you might be thinking, could this be encephalitis? And that's fair, but you wouldn't see what you see on the CT head if it was encephalitis. You wouldn't see the kind of multiple contrast enhancing lesions. So that's why it's toxoplasmosis and not herpes. Okay. Oh, how bizarre. I had two more questions, but they are not here. Sorry, guys. Technical difficulties. Um, Let me go back. I think it might have been in the other one. Okay. Okay. So the answer to this question is the caudate nucleus, which most of you guys said. So this patient has Huntington's disease. How do we know that? So they have involuntary movements of, sorry, his face, of the face, and this then spreads to limbs, and these movements are jerky, fidgety, and semi-purposeful. So that suggests Huntington's chorea, and they've developed over an extended period of time, and the final kind of giveaway is Huntington's is the patient's father had similar symptoms for a long time as well and associated dementia. And as we talked about before, Huntington's does progress into dementia, and it shows a genetic aspect to the condition. And yeah, if their father had similar symptoms for an extended period of time, then it probably started when they were younger rather than when they were really old. And that suggests Huntington's. So yeah, those are the questions I made. I hope they were useful. Now I'll go back to the presentation. Oh my God. Sorry about the technical errors. Um, okay, cool. So for the last part of the presentation, I'll be talking about biochem. So biochem is very high yield in lab. It comes up all the time, and it's really important that you guys understand the basic principles, and the main kind of high yield conditions that come up. So, some quick facts. Fluid balance. In a 70-kilo man, there's around 42 litres of water, and about two-thirds of that water is inside cells, that's 28 litres, and a third of it is outside cells, and is 14 litres. And in that 14 litres, about three-quarters of it is tissue fluid, and a quarter of it is circulating as plasma. So you guys probably know this from preclinical, the iron values, but you also get given them in lab med, so you don't have to memorize them. And this equation, however, you do have to memorize. So if you don't already have this in your notes, it's worth writing it down. So osmolarity is equal to 2 times the concentration of sodium plus the concentration of urea plus glucose. So this you won't get given. So yeah, just memorize that. Okay, everyone got that? I will move on. So the main principles of fluid distribution are Starling's forces. So you have the oncotic pressure drawing water back into the capillaries, and you have the hydrostatic pressure pushing water out from the capillaries. And it's the balance of these forces that kind of determines the quantity of tissue fluid you have. And these are the various factors that affect fluid distribution. So, oncotic pressure. So that's pressure that's created by the proteins within the capillaries, and this if there are changes to the protein concentration within the blood, that leads to edema. So that's because you reduce the oncotic pressure in conditions like liver failure because the liver isn't producing enough albumin, or in renal failure where your kidneys are excreting the albumin. And that reduced oncotic pressure means there's less of an inwards force drawing water back into the capillaries, and that leads to water leaving the capillaries and being present as tissue fluid, and that's what causes the swelling you see in edema. And the fluid distribution is also affected by the permeability of the capillaries, which, for example, in sepsis, you have vasodilation and an increase in capillary permeability so that immune cells can move outwards. And this also affects the fluid distribution and blood pressure, which is why the blood pressure falls so dramatically, and leads to hypotension in sepsis. And also lymphatic drainage. Okay, so moving on to the hormones that affect fluid balance. Okay, so ADH changes free water, and the input and output of water through the kidneys. So, the most kind of sensitive regulator that leads to the release of ADH is blood osmolality, and that's detected by osmoreceptors in the hypothalamus, which are very sensitive and they can detect changes of up to 1 to 2% in the osmolality of the blood. And the ADH then acts on V2 receptors in the distal convoluted tubule and causes the movement of aquaporins to the surface and insertion into the cell membrane, which leads to more water being reabsorbed and a small volume of concentrated urine being produced. So you retain that water in the body, and this combats dehydration. Then you have aldosterone. So you guys are probably very familiar with the renin, angiotensin, aldosterone system, so I'm not going to go into that in too much detail. It's very preclinical. And but it is activated by hypovolemia, and the renin activates causes the conversion of angiotensinogen to angiotensin 1. That's converted to angiotensin 2 by ACE, and then angiotensin 2 stimulates the release of aldosterone by the adrenal glands, and then the aldosterone causes the retention of sodium and the excretion of potassium. So sodium and potassium always act in kind of opposition to each other. So aldosterone causes the sodium levels to go up, but the potassium levels to go down. And that's a very important concept for like the other conditions that we'll come on to in a bit. Okay, so diabetes insipidus, you have a lack of production of ADH, or where the kidneys are resistant to the ADH essentially, and it has no effect, which leads to a failure in the concentration of urine, and this leads to a lot of water being lost from the body. The main symptoms of diabetes insipidus are polyuria and polydipsia. So polyuria, you're going to the toilet a lot, you're weeing a lot, and in response, you become dehydrated, and that makes you drink a lot of water. And this condition can be quite debilitating because these patients need to go to the toilet, you know, several times at night. They're waking up, they're tired, they're constantly dehydrated. So, yeah, not a very nice condition to have. There are three types. So, nephrogenic, which is where your kidneys are resistant to the ADH. And there are various causes of that that you should be familiar with. So it can be caused by lithium, which is used as a treatment for bipolar disorder. It can be caused by polycystic kidney disease and also iron imbalances. So hypercalcemia and hyperkalemia can also cause diabetes insipidus. Also, you have cranial diabetes insipidus. So in cranial, you don't produce enough ADH, and that's due to head injuries, tumors, aneurysms, sarcoidosis, anything that affects the hypothalamus or the pituitary and leads to you not producing that ADH. And then finally, you have psychogenic. And in psychogenic, it's where you don't really have a problem with the way your body either produces or deals with ADH. It's just you drink too much water. And that can be if you're a psychiatric patient or if you're taking any, illegal substances which stimulate an increased consumption of water. And the way to differentiate between these three different types of diabetes insipidus is to do a water deprivation test. So, in a water deprivation test, you don't give the patient water for an extended period of time, normally about 8 hours, and then you see how their urine osmolality changes in response to that. And you also give them synthetic ADH or desmopressin, and see if that then corrects that deficit, or if there's still no response to that ADH. So if you have craniogenic DI, then you would have a low urine osmolality after you've fluid deprived them. But then after you give them desmopressin or ADH, that osmolality skyrockets up and it's normal all of a sudden. And that's because here you don't have any ADH. So you're producing lots of dilute urine and you're losing your body mass. And then after you give ADH, the kidneys are happy, they're responding to that ADH, and you're able to concentrate your urine again. In nephrogenic DI, on the other hand, you have a large volume of dilute urine, so a low urine osmolality, and that does not change. So in both situations, after fluid deprivation, after you give them ADH, there is no change, and the urine remains dilute and the osmolality low. And finally, in primary polydipsia, there's no problem at all. So after fluid deprivation, you're producing concentrated urine, and then after desmopressin, you're still producing concentrated urine. Okay, so cons is primary hyperaldosteronism, and you'd be thinking about cons if you have a patient and they have treatment resistant hypertension. So you've tried, your ACE inhibitors, your beta blockers, your diuretics, whatever, and they have not worked. So you'd be thinking, is there a secondary cause for the hypertension? So you'd want to screen young patients who also have hypernatremia and hypokalemia. And it's where you have too much aldosterone, which leads to your kidneys retaining sodium and getting rid of potassium. And this constantly high level of aldosterone also suppresses renin through the renin angiotensin aldosterone system. And because of that, you would see an elevated aldosterone to renin ratio, and that's the investigation you'd do. So the causes of cons, most commonly it's an aldosterone secreting adrenal adenoma. And you can also have hyperaldosteronism due to bilateral adrenal hyperplasia, which is more common. Okay, so moving on to Addison's. Addison's is very serious and it's a medical emergency. So you'd be thinking of Addison's if someone has these symptoms. So if they're suddenly feeling very tired and weak, if they have weight loss, abdominal pain, vomiting, these symptoms are quite generic. So it's quite hard to kind of say, look at one of these and go, oh, that's definitely Addison's. But if you did, for example, a VBG, they would have a low sodium and they'd have a high potassium. And that would point you in the direction of adrenal insufficiency and Addison's. And they would also have hypotension if you were to take the ROBS, and they might have pigmentation. So that's a kind of classic feature of Addison's. They might have pigmentation of their palms, of their buccal mucosa, and also other autoimmune diseases as well, because as I said last week, autoimmune diseases kind of come in families. So if you have one, so if you have Addison's, you're more likely to have others. So pernicious anemia, Graves, um, various other conditions. So to test for Addison's, you'd want to do a short syntactin test. So syntactin is essentially just a synthetic version of ACTH. And you're using a stimulation test here because every time you have an insufficiency or a deficiency of a hormone, you'd want to test it by stimulating the release. Conversely, if you have too much of a hormone, you'd want to do a suppression test. So, for example, for Cushing's, you'd want to do a dexamethasone suppression test to see if the levels are suppressed in response to synthetic steroid. But in this condition, Addison's, you want to see if you are producing any adrenal hormones. So if you're producing any cortisol, any aldosterone, any androgens in response to stimulation by synthetic ACTH. So if you give them syntactin and there is a response, then that shows that the adrenal glands are still functioning, but the pituitary and the hypothalamus, that part of the axis is not functional. However, if there is no response, then that shows that the adrenal glands simply are not responding, and the problem is with the adrenals. Okay, so moving on to hypernatremia. So that's where you have blood sodium concentrations of greater than 145 millimoles per liter. And it's not that common, but it does present quite classically with the symptoms of muscle weakness, seizures, coma, and confusion. So these are the main causes. So there are three main arms of this flowchart. So if you're losing both water and sodium, if you're losing water but more water than sodium, and vice versa, or if you're taking in too much sodium. So if you're losing more water than sodium, you'd be thinking of renal losses, so osmotic diuresis. So if you have diabetes, if you have high glucose levels, also extra renal losses, so diarrhea, sweating, things like that. If you're losing water but not losing sodium, and you have normal body sodium, then this could be due to diabetes insipidus, like we talked about before. You're producing large volumes of dilute urine, and also respiratory losses of water. And finally, if you have excess sodium intake or reabsorption. That can occur if you have too much aldosterone, because that would cause increased sodium retention but increased potassium excretion. Also, if you have Cushing's, if you are given IV fluids, because these contain sodium chloride, and if you have hypertonic dialysis as well. Okay, so hyponatremia comes up quite a lot in lab med. So hyponatremia is quite serious, and it's where the blood sodium concentration is less than 135 millimoles per liter. Um, it is normally asymptomatic, but if the blood sodium falls below 120, that's where you start to run into problems and it can progress into seizures or a coma. However, the initial features of hyponatremia are quite generic, so confusion, headaches, nausea, just the general symptoms of iron imbalance that we talked about. Okay, so this is a really important flowchart from LabMed that is really important for you guys to kind of commit to memory. So, if someone has hyponatremia, the main question you'd be asking next is what is their osmolality? So, if their osmolality is high, then that's likely due to some kind of osmotic agent. So, if they have too much glucose in their blood, or if they're given mannitol, if they have cerebral edema, for example. If they have a normal osmolality, that's likely due to pseudohyponatremia that we'll talk about in a bit. And if they have a decreased osmolality, that's due to changes in the extracellular fluid volume. So hyponatremia can be due to an artifact, so induced by the lab, and this might be due to delays in analysis, and it might be due to pseudohyponatremia as well. So pseudohyponatremia is where you have elevated concentrations of either lipid or protein in the blood, and that leads to low sodium concentrations upon analysis. But the actual concentration of sodium in the blood is normal, and there's no problem there. It's just when you're in a lab and the machine is estimating the amount of sodium, that calculation is reliant on the lipid and protein content within the blood. So if that's changed, then the entire equation will shift, and the it will subsequently calculate a low sodium due to imbalances in the lipid and protein content. Okay, so SIADH is another cause of hyponatremia, and it stands for syndrome of inappropriate ADH secretion, sorry, ADH release. Um, so the clinical features of SIADH are hyponatremia, but this is hyponatremia with a low osmolality. So, like I said before, if you have hyponatremia, you want to be questioning what the osmolality is, and in SIADH, it will be low. And it will be low because you're producing too much ADH, and that ADH is causing you to retain water, and that will lead to dilution of the blood, and the sodium concentrations will fall. However, urine osmolality will be very high. And importantly, the sodium loss in the urine will be greater than 20 millimoles per litre. And this is how you differentiate it from normal dehydration. So, in normal hypovolemia, the urine sodium loss will be less than 20 millimoles per litre. But in this case, because you have too much ADH, and you're not able to retain that sodium because that's controlled by the renin-angiotensin aldosterone system, you're going to be losing that sodium, and there will be a lot of salt wasting in SIADH. So a patient with SIADH will be euvolemic, so you won't see any signs of fluid overload, no kind of swollen ankles, anything like that, and yeah, no edema. And they will normally have normal renal, adrenal, and thyroid function as well. And there are lots and lots of different things that can cause SIADH. So it can be caused by lung disease, so TB, pneumonia, CNS disease, all the conditions we talked about previously can cause SIADH, can be due to drugs, also tumors, and can be released post-surgery due to pain, and also if the patient is on drugs like opiates or barbiturates, then there is a chance of them developing SIADH. Okay. So the management of SIADH is quite important, and it's a very kind of sensitive, difficult thing to manage because you can't kind of correct the sodium levels rapidly because that would lead to central pontine myelinolysis or CPM. And this is, a disastrous condition that you want to absolutely avoid. So you want to correct the sodium levels slowly by fluid restricting the patient, and you want to do that at a slow rate. So, for example, if the SIADH develops slowly, then you'd want to correct it slowly. And if it developed rapidly, then you'd want to correct it a bit faster. So it really just depends on the individual patient and the rate at which the condition developed. So overcorrection is a bad idea because the pons is very sensitive to sodium levels, and if you correct it too quickly, then it might lead to demyelination of the pons, and the myelin sheaths could be destroyed, which would lead to irreversible paralysis. And yeah, that's not a good idea. So that would present with quadriplegia, facial weakness, and difficulty swallowing. And yeah, like I said before, it's irreversible. CPM, some patients are at an increased risk of it. So patients who are malnourished, if they're cachectic from cancer or cancer therapies, and if they have anorexia or chronic alcoholism. Okay, so finally moving on to acid base. Um, I'm aware that I've been talking for quite a while now, so I will go through this quite quickly. So Henderson-Hasselbalch equation is here, and that's something you guys have done in preclinical before, I'm sure. Symptoms of acidosis, the classic generic symptoms, so nausea, vomiting, tiredness, confusion, and alkalosis, you might have symptoms of low calcium. So that would be tingling in fingers and toes, and if it progresses, then seizures and coma. So um, you get a low calcium if you have alkalosis because the calcium takes the place of the hydrogen ions, and that causes the free calcium levels in the plasma to drop. Okay, so VBGs. You'll have to interpret lots of VBGs in LabMed. It's an exam classic. So the main thing you'll be looking at is, first of all, is it acidosis or is it alkalosis? And once you've established that, what is the CO2 level? So if the CO2 level is high and it's acidosis, then you'd be thinking respiratory acidosis. If the CO2 level is low and it's alkalosis, then you'd be thinking respiratory alkalosis because the changes are concordant. If not, you'd be thinking metabolic acidosis slash alkalosis. And then you'd be looking for any compensation. So based on the bicarbonate levels and based on the CO2 levels. Okay, so respiratory acidosis, the main causes of this are CO2 retention. So any condition you can think of where the body is retaining CO2 causes acidosis and a high partial pressure of carbon dioxide and a low pH. So that's COPD, respiratory depression. So if someone's just taken a morphine overdose, then you would be breathing at a slower rate and retaining that CO2. Also, if you have scoliosis or some kind of skeletal anatomy problem where your gas exchange is impaired, then you'd also be retaining CO2. Emergencies like flail chest, where gas exchange is less efficient, and also various types of muscular dystrophy. For alkalosis, it's the opposite. So you'd have a low partial pressure of carbon dioxide accompanied by a high pH. So you'd be thinking of conditions that cause your respirate to increase. So if you're having an anxiety attack and you're hyperventilating, then you'll be blowing off CO2 at a rapid rate. Also, if you're mechanically ventilated, but they haven't quite got the rate of ventilation right and you're overventilated, that could lead to respiratory alkalosis as well. And metabolic acidosis, first of all, if you see a metabolic acidosis, you'd want to ask yourself, is this normal anion gap or is this high anion gap? And the normal range for an anion gap is 10 to 20. So that's important for you guys to remember. Remember 10 to 20. Um, that's normal. And to calculate the anion gap, learn this formula. So sodium plus potassium minus chloride plus bicarbonate. So you add up the cations and subtract the anions from that. So this is quite an important formula, and I don't think they give it to you. But yeah. So if it's a raised anion gap, then you'd want to think of situations where you'd have excess acid in your blood, but normally from kind of lactate, if you have ketones, diabetic ketoacidosis, ethylene glycol poisoning, situations like that where you have excess organic acid in the blood. So that would be raised anion gap. And if you had normal anion gap, you could have that because of renal tubular acidosis, Addison's, and diarrhea. So I remember that as RAD, RAD. So renal tubular acidosis, Addison's, diarrhea. That's the three that cause normal anion gap acidosis. So type 1 renal tubular acidosis is a problem with the distal convoluted tubule. And this is where you have decreased hydrogen ions being excreted. And because your body is retaining those hydrogen ions, the pH drops and you develop a metabolic acidosis. Type 2 renal tubular acidosis is a problem with the proximal convoluted tubule. And this can be due to various reasons. So you might have Fanconi syndrome where you're not absorbing um, bicarbonate, glucose, amino acids in the proximal tubule as well. Wilson's disease, where you have too much copper and it's affecting absorption. Paraproteins, amyloid, anything that deposits in the kidney and affects the ability of the nephron to reabsorb bicarbonate, glucose, etc. And you would have a loss of bicarbonate. And because you're losing the bicarbonate, the blood pH drops and you get acidosis. And finally, type 4 renal tubular acidosis is hypoaldosteronism. So that would be Addison's, and you have impaired potassium reabsorption because you don't have enough of the aldosterone. Um, and yeah, you're essentially just wasting the hydrogen ions from your body. Oh, sorry, not wasting, retaining the hydrogen ions in your body. And this would have a normal anion gap. Okay, so metabolic alkalosis, you normally get that when you're losing hydrogen ions. So this can be through the kidneys or it can be through the GI tract. And you can also get metabolic alkalosis if you ingest alkali, and that can be iatrogenic. So if you, for example, have too much of an antacid, for example. Okay, so finally, I'm going to talk about calcium dysregulation. So, hypocalcemia is very serious, and the main kind of presentations of this would be paresthesia, so numbness, tingling, pins and needles around your mouth or in your hands and feet. Also, carpopedal spasm, so your hands and feet start to contract as you don't have enough of the calcium. And as it progresses and becomes more severe, it can lead to seizures and spasm of your larynx. And this can be fatal. So that's why it's so important to pick up hypercalcemia and correct it. Hypercalcemia, on the other hand, presents with the classic bones, stones, moans, and groans. So if you have too much calcium, then you'll be at increased risk of fractures as bone remodeling goes wrong. Also, moans, because you're going to be constipated, and hypercalcemia also makes you feel quite nauseous and can lead to vomiting as well. Stones, so you'll be at a higher risk of kidney stones as well because the calcium can precipitate out of the urine and cause stones. And also psychiatric problems. So you're going to be tired, you'll have low mood. It can also lead to psychosis. So quite like a broad range of symptoms. And in a question stem, they might just say patient has constipation and has recently had a low mood and fallen and broke his hip recently, for example. So at like initial, a first glance, like these look quite detached from each other. So that's why if you see any kind of combination of these symptoms, you'd want to be hyper aware and thinking of hypercalcemia because at first glance it's not super obvious. Um, so yeah, cool. So moving on to parathyroid hormone. So PTH acts to increase plasma calcium by acting on the bone and the kidneys. So on the bone, it activates osteoblasts, which then subsequently activate osteoclasts. So there is an increased rate of bone resorption, and the bone is broken down to release calcium. And in the kidneys, you're going to increase calcium reabsorption in response to PTH. And you also have increased activation of vitamin D, which then acts in the GI tract to increase calcium absorption. And parathyroid hormone also decreases the phosphate levels within the plasma by acting on the kidneys to inhibit the sodium phosphate transporter. On the other hand, vitamin D increases the levels of both calcium and phosphate because vitamin D is osteoprotective. So its main purpose is to protect bone, and bone contains both calcium and phosphate. So you want to be able to, so it functions to increase levels of both of these ions so they can be incorporated into bone to prevent osteoporosis and osteomalacia. So, yeah, in bone, vitamin D binds to the rank receptor and um, also stimulates the release of calcium. And in the small intestine, it promotes the reabsorption of promotes the absorption of calcium through apical membrane channels. And this is a useful kind of diagram showing the difference between primary, secondary, and tertiary hyperparathyroidism. So in primary, you have too much PTH due to a problem directly with the parathyroid glands. And this is most commonly due to adenomas, but it can also be due to hyperplasia. And in primary hyperparathyroidism, your PTH is going to be high, but your calcium is going to be very high. And in secondary, you have too much PTH, but this is due to problems outside of the parathyroid gland. So it's most commonly due to systemic problems like a vitamin D deficiency, which stimulates excess release of parathyroid hormone. And finally, tertiary hyperparathyroidism is a chronic condition. So it's where you have we have secondary hyperparathyroidism, but then that becomes chronic, and there's complete dysregulation of this axis, and you just have chronically high levels of PTH. And this is most commonly caused by chronic kidney disease because you have impaired activation of vitamin D, leading to low calcium levels, and this promotes the secretion of PTH from the parathyroid, but the feedback regulation is broken, so the PTH just keeps being released and kind of gets out of control. And this is another useful table showing the levels of calcium, phosphate, and ALP in the different types of bone disease. So, osteoporosis, you have normal levels of the three of them. There's not going to be any changes you can see on the blood test results. In osteomalacia, you have low levels of calcium and phosphate, because you have vitamin D deficiency. And like I said before, vitamin D acts to raise levels of both calcium and phosphate. So if the vitamin D is low, then you'll have low levels of both of these, but you'll have high levels of ALP because your body is trying to stimulate your osteoblasts and kind of maintain that bone density. In Paget's, you have lytic lesions of the bone and you have excess activity of the osteoclast and the osteoblast. And because of that, you have sky high ALP activity. And that'll be the main giveaway that it's Paget's disease. In myeloma, you'll have high calcium, but the rest of them tend not to be changed too much. And bone mets, you might have lytic lesions or sclerotic lesions depending on the type of tumor that has metastasized to the bone. So you have sclerotic lesions with prostate cancer specifically, and lytic with the other types of cancer that are listed here. So because of that, you have bone being broken down, and you have high ALP, high calcium, and phosphate can also be high or normal. And yeah, primary hyperparathyroidism, you'd have high ALP and high calcium, but conversely, you'd have a low phosphate because PTH acts to increase calcium and simultaneously reduce phosphate levels. Okay, so vitamin D deficiency, we've kind of covered this throughout the previous slides, but the main thing to remember is you develop rickets in kids because you have undermineralization of the growth plate. And in adults, because your growth plates have already fused, it's called osteomalacia. And osteomalacia is the equivalent, but it's the undermineralization of any region of bone. It doesn't necessarily have to be of the growth plate specifically. And the main symptoms of vitamin D deficiency are bone pain, muscle pain as well. Also, you'll be more prone to fractures, like stress fractures of your toes, and also your fibula. And you'd have a low bone mineral density as well. So you'd want to do a DEXA scan. And yeah, so causes. You have various causes. So a lot of people in the UK are just vitamin D deficient due to the lack of sunlight here. And renal failure is another big cause because the kidneys are important in the activation of vitamin D, and that's obviously impaired if you have chronic kidney disease. And there are certain drugs like anti-epileptics and anti-TB drugs that prevent the liver from activating vitamin D as well. Okay, so this is the last slide. It's on familial hypercholesterolemia. So the kind of pathognomic sign of FH is tendon xanthomata. So you'd see the yellow kind of lipid deposits on the patient's hands. You also have other signs like xanthelasma and various other deposits of cholesterol, so corneal arcus, things like that. And if you have FH, you have a massively elevated risk of developing cardiovascular disease, and the patients need to be put on statins as soon as they're diagnosed to lower their cholesterol levels. And secondary hyperlipidemia is a lot more common than primary hyperlipidemia, so conditions like FH. So it's mostly in the form of high cholesterol, and you can have high cholesterol levels due to conditions like hypothyroidism or problems with the gallbladder, like cholestasis. And you can also have high triglyceride levels as well. So if you have high triglycerides, you'd be thinking more along the lines of, is the patient obese? Does the patient have diabetes? Because these two conditions increase the levels of triglycerides independently of cholesterol. And if they have both, you'd be thinking of nephrotic syndrome. So problems with the kidneys where you lose the protein carriers in the blood for triglycerides and cholesterol, or you'd be thinking of chronic renal failure if the problem's been going on for a long time. Yeah, so that was quite a long session. Apologies for how long it was. I had a lot of content to get through, but I hope it was useful for you guys. If you have any questions, then don't hesitate to ask me. And if you would like the slides, then here is the QR code. And any feedback would be much appreciated because it helps us to learn what you guys want and what you don't want. So, yeah, so please fill that in. And thank you for coming. And I think your formatives tomorrow, so good luck for that as well. Has everyone got the QR code? Um, Perfect. I think that's fine. Cool. Thanks for coming, guys. And yeah, good luck.